Hello, my name is Meg Huang. I'm the Executive Director at the Center for Connected Health Policy. Welcome to our Telehealth 201. These are videos that are meant to be short educational videos that dive a little bit deeper into specific issues related to telehealth policy. Today, we'll be talking about Medicare telehealth coverage. And please note, I do have a specific date on the PowerPoint slide, October 31st, 2021. That's simply because a lot of the telehealth policies right now are in flux. So if you are looking at this a few months or maybe a year later, some of the policies may have changed. So I really recommend that you do consult with the CCHP website to make sure you have the most recent information. But a lot of what I cover today will help you kind of understand how Medicare telehealth policy is developed. So a lot of information will still remain relevant. A few disclaimers before we get started today. Note that any information provided in today's talk is not regarded as legal advice. It is strictly for informational purposes. If you do want to form a legal opinion, CCHP always recommends that you consult with legal counsel. And if I happen to mention a company or show some type of product, know that neither I nor CCHP has any type of relevant financial interest, arrangement, or affiliation with such an organization. So Medicare policy around telehealth. Medicare actually approaches telehealth policy in their program in two ways. You have your telehealth policies and you have your communications technology-based services. Now, what is the difference between the two? Because both utilize telehealth technologies to deliver the services, but they are distinctly different policies, at least in CMS's, the Center for Medicaid and Medicare Services, or Medicare and Medicaid Services, the agency that administers Medicare. They are distinctly different ways of how they handle them. So for telehealth policy, these are services that in CMS's eyes replace an in-person service. So they're a one-to-one replacement for something that typically is provided in person. For example, I go in and see my primary care doctor for an office visit. I can do that via telehealth, and that's an office consultation, and that's a one-to-one replacement. And the policy surrounding these sort of in-person replacements via telehealth is really embedded in federal law, in federal statute, in the Social Security Act, and that's the citation that you have there. It's 42 USC 1395 MM. That's the section of telehealth policy that impacts Medicare. And it really creates like the parameters as far as like how Medicare is to cover telehealth delivered services. So it really notes on there, like, what modality is used, who the providers are to provide the services, and like the geographical or location limitations on there. Then there's another sort of grouping of services called communications technology-based services. And these are services that utilize telehealth technologies to deliver those services, but they're not, in CMS's eyes, considered a one-to-one replacement for an in-person services. These are services that are made possible by the technology itself. So there's not something that you typically do in person, but technology, because it's so advanced now, we can do them, and CMS has found them to be beneficial to patients, so they want to cover them. An example is, I'm a patient with hypertension. I'm taking blood pressure readings several times a day, and that's being sent electronically from my blood pressure reading monitor machine to my provider, who's like recording or receiving those readings every day. And then maybe I'm doing it for like a period of time, like over 7 days. And then the doctor will like look at those and get in touch with me and see like what next steps are. I typically would not be doing that in person. I'm not going into my provider's office like several times a day to get my blood pressure reading done. And I'm not doing that for like consecutive days, like 7 days in a consecutive time period. I'm not doing that in person, but because technology now allows that to happen, CMS is saying, this is kind of stuff that we want to like cover, but it's not an in-person replacement. So we're going to call this communications technology-based services. It's not telehealth, though it's using those telehealth technologies. So we're going to call them communications technology-based services, and we're going to create other policies and payment schedules for these things. And they don't fall underneath like the telehealth category, and they don't fall underneath those telehealth limitations or requirements that we see for telehealth services as CMS views them. So keep in mind two different separate buckets of policy here when talking about services delivered via technology. There's telehealth that Medicare says is telehealth. controlled a lot by what's in federal law, and then communications technology-based services, which is policies that Medicare itself, CMS itself, has created in order to how they want to administer it. So for Medicare policies, there are usually 4 elements that these policies touch upon, and these are also 4 elements that federal law touches upon as well too. So that's the service, location, modality, and the provider. What service is covered if it's delivered via telehealth, where the location of the patient is when the telehealth service takes place, and then what modality is used to deliver those services, and what provider is eligible to provide those services and get reimbursed by Medicare. And most of these, for the most part, will require statutory change. So you will require Congress to act in order to change what the current policy is. So there are some things that CMS can do administratively, which means that they don't have to wait around for Congress. But a lot of the major items here that people consider are barriers to telehealth, such as, the rural limitation on where the patient's located at the time of the service, really does require Congress to act and the president to sign a bill once Congress has passed it. So we'll take the first one, service. And this is actually the one area where CMS actually does have the most leeway and control over what they decide. CMS does decide what specific service codes are covered underneath the Medicare program when it's being delivered via telehealth. And they do that by specific CPT or HCPC codes. So these are the billing codes that give a definition for a specific service. And they say these are the codes that we are going to reimburse if they are provided via telehealth. And the way that they do this is they usually add new codes to the eligible list that we call the telehealth service list. So there is a list of what codes you can get reimbursed for if you provide that service in the Medicare program, you provide it via telehealth. And they add new codes to that list sometimes, and they do it through what they call a Category 1 test or a Category 2 test. And basically a Category 1 test is if you are proposing another code to be added to that list, if it's very similar to a code that currently exists on that list, then it passes a Category 1 test. And that's usually how a lot of new codes get onto that permanent telehealth list. Then you have a Category 2 test, which is there has to be evidence that the code that you're proposing to be put on the permanent telehealth list can be effectively provided via telehealth. And the question is well, what's the evidence that you need to provide that? So is it I have 50 peer-reviewed studies that show that this is going to be effective to provide the service via telehealth? Is that enough? Or do I only need 10 studies or something? And it's never really been made clear, which is why most services get on the list through a Category 1 test. And we see when these services get on the list through the physician fee schedule. For those who are not familiar with it, the physician fee schedule is a set of updates and regulations that CMS makes to the Medicare program that they propose the year before it's to take place. So for example, for 2022, their proposals for that particular year were made in July of 2021. And they sent out a draft of their proposals, they take public comment, and then they finalize them towards the end of the year in November or December. And then they go into effect January 1st of the following year. So that's usually where we see what new services they're going to add to that permanent telehealth service coverage list. And that is also in between those times, that's also the time that the public can send in to CMS saying we think you should add this HCPC or this CPT code to that telehealth permanent list, because whether it passes a Category 1 test or a Category 2 test, they would list a reasoning for why it should go on there because it passes one of the 2 tests. Location is the other thing. And this is the one that is really limiting on where telehealth can take place. So there are 2 location requirements that need to be met before telehealth services will be covered via by CMS, and that there's a geographic requirement in that the patient needs to be located in a rural area, and there's a specific definition for what rural means. And then the building that the patient is located in when that service takes place. And there's a specific list of the eligible types of locations, such as a doctor's office, a clinic, a hospital. Sometimes they allow the home to be an eligible site for just a couple of services, but they're very specific on what that list is. And both conditions need to be met in order for that interaction, the telehealth interaction, to qualify for reimbursement in the Medicare program. These location requirements are embedded in federal law. So this is not something that CMS has control over. This would require a statutory change by Congress. And again, bill passes Congress, president has to sign it, and the CMS will implement it. So it's not something that they have control over. They have to wait for Congress to act. Now, interestingly enough, this is all talking about the patient location. The law is silent, and CMS's policy is usually silent on like where the provider is located during the telehealth interaction. Modality. Modality is a little bit trickier. So in federal statute, it says that telehealth services are provided through a telecommunication system. But in federal law, it doesn't say like exactly what telecommunication system means. It does say later in the section that like it has in that definition, at least for Hawaii and Alaska, it will include store and forward for telehealth demonstration project. But other than that, there's no other specific definition for what telecommunication means. So there's no specific definition for modality. When CMS implemented the federal law years ago, they did add the word interactive in regulations before telecommunication systems. So CMS views it as it's an interactive telecommunication system. So that does kind of narrow things down a bit, because that essentially means like store and forward and remote patient monitoring are out from that telecommunication system definition there, with the exception of, again, Alaska and Hawaii, because that's in federal law. So while they weren't required to add the word interactive in regulation, they did. So CMS did narrow that down for themselves. However, still, there was no specific definition for telecommunication system means. So that does give CMS some leeway in how they can define that. And they actually have taken advantage of that in 2021 when they were looking at policies for implementing in 2022 by including audio only in there, at least for mental health services. So they are proposing allowing audio only to be used to provide mental health services if certain conditions are met. And they're basically doing that because they have that flexibility to define what telecommunication system means. Provider. Again, this is something that is very specific in federal law. So again, not an area where CMS has a lot of leeway with, but as I will get to it in a moment, there was a little bit of creativity that CMS has done. So in federal law, they do have a very specific definition as to what type of provider could be reimbursed underneath the Medicare program if they use telehealth to provide services. And they specifically spell out, they said a physician who's defined underneath a certain section of the Social Security Act, or a practitioner as defined underneath another section of the Social Security Act. And so that's pretty definite, what type of providers they are. So basically that actually eliminates a lot of other types of potential providers, such as your allied health professionals like OTs and PTs, but also federally qualified health centers and rural health centers. Now, for those of you who do follow telehealth policy fairly closely and are aware of the physician fee schedule proposals for 2022, you might be asking, but wait a minute, I thought that they said something about FQHCs and RHCs and mental health and providing services. So let's get to that. So basically why I said that, let's go back. Why I said that was kind of interesting is that what they did with their physician fee schedule for 2022 is that CMS did not redefine what a provider was, but they redefined what a mental health visit meant for an FQHC and RHC. So what they added to the definition of mental health visit for those health centers was to say that it would include providing services via an interactive telecommunication system. So they could provide services for mental health via video or audio only. So they didn't add the FQHCs and RHC onto the provider list. They redefined what a certain type of visit meant for them. What that also means is, should that proposal pass, those mental health visits for FQHCs and RHCs would not be considered telehealth for those entities, because they haven't added them to the provider list to be eligible to provide telehealth services. They just redefined what that type of visit meant for them. So communications technology-based services, as I mentioned earlier, this category was created by CMS. So those telehealth statutory limitations do not apply, but they did create like their own limitations there. So for example, they created their own fee schedule as to like, you know, what the reimbursement rate would be for these services. And they created like other types of limitations around there as well. You see all modalities are available underneath the CTBS services. So you'll see like video being like allowed to be used for that, store and forward, remote patient monitoring and audio only services, e-consult, virtual check-in. They're all represented some way underneath the grouping of CTBS, even though they may not be utilized for every service, but you do see them appear for in like some of the services there. For example, CTBS has a cluster of services that they call chronic care management services, and that's your remote patient monitoring services. And again, as I want to reiterate, these are not a replacement for in-person services. If they were, they would be considered telehealth services in CMS's eye. So they are their own different category of services there. And the reason why I really want to make this distinction is like during the pandemic, I think this got a little bit confusing for some people who were newer to telehealth. And then they were wondering why they were getting so much less for what they thought they were doing was like an in-person office visit, like a regular substitution for an in-person office visit, but they were doing it via telehealth, and then they were only paid like $15, but they were coding it as like a CTBS service, a virtual check-in visit, which only pays about $15. So that's a quick check-in visit type of thing. So it's like very, very important to like keep these certain differences in mind when you're providing services and when you're doing your billing in order to make sure that you're accurately capturing what type of service that you're providing. And so you're being accurately reimbursed by CMS. And so that concludes sort of like our overview of the telehealth policies within Medicare. So I did not go into really deep detail as to like, you know, these are all the list of providers who are eligible to provide services underneath the permanent policies. You can find that on our CCHP website. I just wanted to give you a little bit of background on like what all these policy areas are, how they're formulated, how much control CMS has for it. So you have a better understanding of like how that policy is created and like why certain things happen with like certain policies and why they don't happen. So hopefully this has been helpful to you, and I hope to see you on a future video. Thank you.